Good afternoon, good morning, or good evening, whenever you will be able to join us in the discussion. My name is Savino Shasha, and today I'm privileged to introduce you one of the topics that often come to discuss into the real life. So how to explain the antibodies testing, and in the specific, the antiphospholipid antibodies testing to our patient. I feel that one of the beauty of our community in ReCONNET is really putting the patient and people living with rheumatic disease at the center of our activity. And this is what we will discuss today with our colleagues. It's my professional, but I have to say also personal honor to introduce you to young and brilliant ERN ReCONNET representative, Massimo Radin. He's an academic researcher and clinical pathologist at San Giovanni Hub Hospital in Torino, and Silva Foddai, transfusion medicine and again clinical pathologist. Today, they will introduce and walk us into the challenge of how to explain antiphospholipid profile to our patient. Massimo, Silvia, thank you. The floor is yours.
Thank you, Savino, and thank you for the audience to give me the chance to participate to this meeting. What I'm going to do in the next 10 minutes is to try to explicate a little bit more APL antibody testing, the methodologies and their limitation, in order to, I hope, give you a little bit more tool to understand your lab report and to be able to participate in a more vivacious interaction with your treating clinician. So without further ado, APL antibodies, so antiphospholipid antibodies, are antibodies that are directed toward phospholipid binding proteins. They are characteristic of the phospholipid syndrome. In fact, they are both marker and diagnostic catalysator of the syndrome. In fact, the presence of these antibodies is necessary in order to the diagnosis to be made, and at the same time, their presence is the way through which the manifestation characteristic of the syndrome, so thrombotic event or pregnancy morbidity, exert itself. APL antibodies are various. Since the first description of the disorder that happened in 1983 by Graham Hughes, different types of antibodies directed to the syndrome were discovered. But so far, clinical guidelines identify only 3 types of antibodies as necessary to be tested in order to confirm or to exclude the diagnosis. And they are lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2-glycoprotein 1. What's important about this type of antibodies? First of all, they need to be tested all together at the same time. Second of all, they need to be tested in a referral lab, which means that we need to test them only in laboratories that know how to treat this type of testing, because the chance for both false positivity or false negative is under the corner. So we need to be sure to give our blood to laboratory testing. There are experts in this type of field. Last but not least, one of the peculiarities of these antibodies is that they need to be persistently positive over time. And international guidelines and a group of researchers decided to give as a lag time necessary to confirm the positivity or in contrary to exclude the positivity for a patient of at least 12 weeks. This lag time that is completely arbitrary was determined because sometimes, especially in case of chronic infection or inflammation, or in case of utilization of some type of therapy drugs, the antibody testing could be false, so in a positive manner or in a negative manner. But moving on, what I want to point out is that these three types of antibodies are tested in two different completely ways. Lupus anticoagulant is tested through a functional assay. What is a functional assay? A functional assay is a laboratory testing that is going to measure the function, so the activity of a biological component. What we are going to assess with lupus anticoagulant is the ability or inability of my blood, so of the patient blood, to clot in a decided time frame, okay? What we are going to measure is not the presence of the antibody, but we are going to understand that the antibody is present because we've got a prolongation of the clotting time. Instead, for anticardiolipin antibodies and anti-beta-2 glycoprotein 1 antibodies, we are going to use a solid phase immunoassay, which means that we are going to detect the presence of the antibody, coating in it in a membrane. We've got so many techniques, but not only the detection of the antibody is determined through this technique, but we are going to determine even in which type of number, in how many copies of the antibodies are present in my blood. So two completely different ways of detecting the antibodies. Now on, I'm going to focus a little bit more on lupus anticoagulant testing because, as I said, all three types of antibodies need to be tested in a referral lab. But specifically for lupus anticoagulant, we need to be aware that this type of testing is very tricky. And in fact, we've got international guidelines from the International Society of Thrombotic and Hemostasis who give the recipe to perform this type of testing because the chance of giving a result that is not solid is very common. First of all, I want to point out that, as the name suggests, lupus anticoagulant was an antibody that was detected for the first time in a lupus patient. And of course, it's called anticoagulant because in vitro, it exerts an anticoagulant pattern. What does it mean in vitro? When I'm running the test in the lab, what I'm going to see is a prolongation of the clotting time. The clotting time is the time in which our blood is able to stop an hemorrhage, and it's counted in seconds. When I've got lupus anticoagulant, I'm going to see in vitro, so in the lab testing, that my blood takes a little bit more time to clot, okay, compared to a normal blood. Another thing that I want to point out is that, as I told you, we are measuring a functional assay. So for us, it's now clear that lupus anticoagulant is a group of antibodies. It's not just one antibodies, because what I'm going to measure is the ability of this type of antibody to determine a biological function, so a prolongation of the clotting time. How is run this type of testing? This type of testing necessity of two types of tests that are run at the same time. So two different methodologies through which I'm gonna angle in a different way the coagulation cascade, okay? So I'm going to use two different types of tests. The first one is called the RVVT, so diluted Russell Viper Venom time. And the second one is SCT, so silica clotting time. Through the utilization of these two tests, I'm going to see if my patient has got a prolongation of the clotting time that, as I told you, is measured in seconds. It's necessary for just one of the two tests to be positive in order to say that my patient has got lupus anticoagulant. But let's go deeper. Every test is run in a cascade way, meaning that if the screening test is positive, we are going to go to the mixing test. If the mixing test is positive, we are going to go to the confirmation test. I want to point out that lupus anticoagulant could be just one of the reasons why my coagulation test is prolonged, so towards an anticoagulation pattern. The other reason could be the utilization of an anticoagulation treatment, or, for example, the presence of lacking of one of the coagulation factors, so of one of the bricks that are necessary for the clot to be formed. I'm going to understand if my patient has got a lack of our coagulation factor or has got lupus anticoagulant, running all these type of tests, as I said, in a cascade way. So in the first part, I'm going to use the blood of my patient, specifically the plasma of my patient, so the liquid part of the of the blood, and I'm going to mixing it with or silica or this viper venom. And then I'm gonna add calcium, and I'm gonna test in second how much time does it take for the blood to form. Of course, I'm going to compare this time to the time that it's needed for the clot to be formed in 120 sample of normal subject, okay? Because I need to have a reference for sure. If my blood is clot in too much time, then I'm gonna go in the mixing test. In the mixing test, I'm gonna add half of the blood of my patient and half of the blood coming from normal sample. I'm gonna mix it up, and I'm gonna see how much time the blood does it take to be formed. If the blood right now is formed in a normal amount of time, I'm gonna say that my patient probably has got a lack of one of the coagulation factor. Instead, if my blood is still anticoagulated, it means that maybe I've got an inhibitor anticoagulant, so lupus anticoagulant. To be sure of that, I'm gonna use an additional part of phospholipid that I'm gonna use and introduce in the blood. And then I'm gonna rerun the test. If the test is now still prolonged, but a little bit more into what are the lag time that is considered to be normal, I'm gonna say that the confirmation test is telling me that my patient probably has got lupus anticoagulant. I know that it could be a little tricky, but I'm gonna try to explain you with the next slide. What you need to know, and that I forgot, is that, as I told you, we are measuring everything in seconds. But as I'm showing you with the slide, these are the lab result that you're gonna have. And in this lab result, you're gonna have not the second, but a ratio. And that's because we need to make our laboratory testing comparable to others. So we are going to make a ratio comparing what is the result in second of my patient, so of the patient that has got lupus anticoagulant, and what is the result in second of people that do not have the disease. We are going to make a ratio, so compare the 2 seconds and come out with a ratio, a final ratio. So we are going to do the same thing. So the ratio understanding for screening, for mixing, that here, because it's a lab result written in Italy is called the mixing part. And then we are going to do the same thing for the confirmation part. As last things, in order to say that we've got lupus anticoagulant, we are going to compare the ratio of the screening part and of the confirmation part. If they go below a value that is considered and formulated by the referral lab, and in this case is of 1.2, I'm going to say that my patient does not have the antibodies. But otherwise, as you can see in these cases, both for both the testing, so PTT-LA ratio or DRVVT ratio, we are going to see that my patient has got a very prolonged time. So the ratio is above the cutoff limits. So in this case, I'm going to say that my patient has got lupus anticoagulant. But not only, I have to say and to report that the testing need to be rerun after 12 weeks. As I told you, in case of, for example, anticoagulation, we can mislead and misread the result. And of course, we need to be sure that an anticoagulation is not present in the blood of the patient. So every time that you are going to perform your testing, you need to remember to your treating clinician that they need to write that down if you are taking anticoagulation treatment or not. And as the last part, I'm going to talk about a little bit about solid phase immunoassay. Solid phase immunoassay are very different. We've got so many techniques, from ELISA to fluorometric to chemiluminescence. What you need to know is that in solid phase immunoassay, I'm going to detect the specific antibody, so anticardiolipin or anti-beta-2 glycoprotein 1, and I'm going to say how much of the antibody is present in the sample, okay? And that's important because I'm going to give a numerical value to my testing. What I want you to bear in mind is that technologies could be very heterogeneous and they are not comparable. So if you are running your test in your referral lab and then you are running your test in another lab, the result could be completely different. So don't be afraid if you find results that are not comparable. Last but not least, I want to tell you that for clinical research, we can use different type of technique, but the one that is considered the gold standard so far is ELISA, so enzyme-linked immunoassay. And this type of techniques use the link of the antibody that we want to detect, for example, beta-2 glycoprotein 1, with another second antibodies that we called recombinant antibodies that has got the ability to detect the interaction of my antibodies that I want to find in the plate that I'm using to detect it. So what I'm going to use in the ELISA testing is a way to understand if my antibodies is present and how many copies of it are present in the sample. To do so, I'm going to use a fluorochrome. The fluorochrome, in case my antibodies is linked to the molecule that I want to find, is going to exert luminosity. I'm going to measure this luminosity, and I'm going to traduce it to a number that I'm going to have on my report. And with it, I finish, and I'm going to pass the ball to Massimo.
Thank you. So I think Silvia brilliantly explained how the testing is performed, but the next question that I'm trying to answer is what is the meaning beyond antiphospholipid antibodies and their positivities? I'm going to try to answer this with some clinical scenarios. The first clinical scenario is represented by a young woman. She's a smoker. She has no clinical history of other diseases. And after a long shift of work, she starts to feel an excruciating pain at her left calf. She goes to the emergency room where she's diagnosed with a DVT. She's a young woman. She has a risk factor, which is smoking, but it's very unusual that a young woman like this, after a long shift of work, develops a venous thrombotic event. So she's tested for lupus anticoagulant and it's positive. After the testing, they test her again after 12 weeks, as Silvia suggested that one should do, and she's confirmed to be positive. So the patient is diagnosed with APS because she has a positive testing of LA, and also she had a clinical manifestation. What should we do next? Something is missing because how can we interpret APL testing? The easiest thing is positive and negative. Everybody can understand that. The patient is positive for APL, so she is an APS patient. Why do we need to test her for other APL, so beta-2 and anticardiolipin antibodies? Because we see this test as an increased risk of developing a clinical manifestation of APS, in the specific of the patient of developing, for example, a recurrence of thrombosis, so another thrombotic event. This is not new, and it's written clearly in the EULAR recommendation for the management of antiphospholipid syndromes in adults, which tell us what are the profile risk of patients with APS depending on their APL positivity. Not only that, but also how strong these positivities are. So, as Silvia was saying, solid assays, for example, for instance, can tell us not only if the patient is positive, but if the patient is strongly positive for an APL antibody. And if the positivities are multiples, the risk is higher. If the antibodies levels are higher, then the risk of developing another clinical manifestation is higher. How can we interpret this in an easier way? The moderator, Professor Sciascia, developed some years ago a score, which is the GAPS score, so the Global Antiphospholipid Syndrome score, which gives a number to the positivities of the antibodies. Not only that, it's included also clinical manifestations such as hyperlipidemia or arterial hypertension, which are traditional cardiovascular risk factors for the development of thrombotic events. With GAP score, you can get an idea of how much the thrombotic score increases depending on the number of positive APL testing. Let's go to the second clinical scenario. It's an easier patient because this patient is a young woman. She's 23. She has no clinical history and she has absolutely no cardiovascular risk factors and a healthy lifestyle. After a routine checkup, the coagulation tests show a prolonged APTT testing. So her blood clotting is prolonged. This should ring a bell in your mind because Silvia explained that lupus anticoagulant acts like this. So in the lab, somebody is thinking about this and tries to test Sarah for lupus anticoagulant. After second level testing, Sarah is confirmed to be positive not only for lupus anticoagulant, but also for beta-2 GP1 antibodies at high titers. So the patient, she has no clinical manifestation, so no thrombotic manifestation, and she's not diagnosed with APS. We call this kind of situation APL carrier. But what should we do? Should we follow up Sarah? Should we give her some medication? Luckily, the EULAR recommendation again comes in help because for patients that are at high risk of developing a clinical manifestation of APS, we can do something about this because we can give the patients a primary thromboprophylaxis with the use of cardioaspirin mainly. And also in asymptomatic APL carriers, this can help them to reduce the risk of developing a clinical manifestation in the long term. This is fundamental because in the long term, we already know that this patient have a high risk of developing thrombosis and thrombotic events, so they should be treated and managed correctly for cardiovascular risk factors. Also, the patient was a young woman of 23 years old, and another thing that is fundamental is preconceptional or pregnancy counseling. So the patient should definitely be followed up. These are two clinical scenarios that should explain some situation of APL testing, but for all the patients that are following our presentation, they all know that it's not as simple as this. So I will ask Silvia to join again for some clinical cases that are more difficult.
Yes, we call this section peculiarities, and we are going to present 3 different clinical scenarios that I guess could be useful for you, because sometimes they can cover some of your thoughts or your question. So Anna is a 76-year-old woman who experienced a superficial venous thrombosis. At the time of the event, she's on tamoxifen, which is a chemotherapy for breast cancer treatment after performing mastectomy 2 years prior. She has no cardiovascular risk factor and has a healthy lifestyle. After a routine checkup, she tested positive for anticardiolipin antibodies of IgM isotype at medium titer. So in this case, even if this patient has gotten antibodies, that is phospholipid antibodies, we have to bear in mind, first of all, that APL antibodies are more useful to be identified in patients that are young. Usually, we tested in patients that has got less than 50 years old, not all the time, but in most of the time. Second things, as I told you before, APL could be falsely positive in subject who's got infection, coagulation. So our patient is now running a treatment, and in this case, the positivity that she has, specifically even for the type of antibodies that we found, that is anticardiolipin antibodies of IgM isotype, is probably related to the treatment that she's doing and to the cancer behind it. So in this case, this subject, even if suffered from a thrombotic event, considering even the place in which she suffered it, so in a superficial vein, is not considered to be affected with the syndrome. Second question, second clinical scenario. Angela is a 28-year-old woman who comes to the clinic for consultation. Her cousin, who is 30 years old, is affected by APS. She wants to plan a pregnancy, and she's worried to be affected by APS without knowing. So, family affected by APS do exist, and a colleague of ours is working in this field and is studying cluster of families that has got APS, like father and daughter, but they are very few of our cohort of patients. And we are still investigating what are the genes that makes the disease to be more prone to happen. But so far, we do exclude that APS patient is something that could be completely hereditary, like the blonde color of your hair, okay? So, so far, we do exclude APS as an hereditary disorder. And I want to remember you that it's a rare disease. So it happens, but very, very in a few cases. So Davide is a 34-year-old man affected by APS, and he is worried because after 5 years, his APL positivity changed completely after being tested in a private lab. So he was positive for all 3 types of antibodies: lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 of IgG isotype. But then, after testing in the private lab, it tested positive only for LA and anticardiolipin of IgM isotype. So what we should tell to Davide, we should calm him, because as I told you before, APL testing needs to be run only in referral lab. So if you are running your test in another lab, in a new lab, you need to be aware that maybe your APL profile could change completely because they are using another methodologies, other cutoffs. But most of all, you need to be aware that only few laboratories know how to run this testing, because as I showed you before, they are very tricky. So we could have false positivity or false negativity. And that's why Davide showed a completely lab report compared to the previous one. And with that, I'm gonna go to Massimo again for the closing remarks.
So we saw that antiphospholipid antibody positivities, it's very important in order to determine the risk of the patient to develop clinical manifestation of EPS. Of course, this is important for the overall prognosis of the patient, but it should be important mainly for the management and follow-up of the patient. So there is a lot that the patient himself or herself and the doctors should do. So mainly focusing on the lifestyle of the patient, on the cardiovascular risk factors that can be modified, and of course, in some moment of the life of the patient, for example, transient risk factors like a long flight, or before pregnancy, these moments should be addressed. And in order to do a correct management and a long-term good prognosis for our patients. Thank you very much for the attention in this webinar.
Thank you very much to Silvia Foddai and Massimo Radin from Torino, and thank you for provide, from a physician perspective, some food for thoughts to how we have to implement the way that we share results with people living with APS, and from the side of patient to provide the educational material that can be handy in order to go over blood results and have a key to interpret that. So thank you for this educational webinar. Your talk is now open for some questions, if any. Otherwise, I can take advantages of the microphone and of my role as a moderator to share with you something that we are often asked to patients and sometimes also from colleagues, like how often should we test for antiphospholipid antibodies? Because sometimes it's clear at the diagnosis time, and Silvia correctly stressed that we need to wait for some months in order to confirm the positivity. What about the follow-up? Every month, every year, every 6 months?
So for us clinicians, thank you, Savino, for the question. So for us clinicians, after the diagnosis is made, it could be necessary to test the patient once a year, but we do not have strict rules about it. At the same time, considering that we are a research group, it's very important to have sometimes the help of patients. And so sometimes we ask them to provide some samples, some additional blood every 6 months, or sometimes every 3 months if it happens, but is something that we decide to do just for research purpose. It's not necessary to test them again so much time. So in a patient that is known since always, from so many years, we could test even them on every 2 years, for example.
Yes.
Perfect. I don't see any other question, and I think that you covered how we can explain to our patient lab test. So with that, thank you, Silvia. Thank you, Massimo, for sharing your time and expertise. And thank you to all the ERN ReCONNET family to give us the opportunity to share and discuss about APS, a disease in which we still need a lot of research, a lot of networking, and joint efforts to improve the quality of life and the outcome of people living with this disease. So thank you very much to all.
Thank you.
Thank you.